Welcome to Rate and Rhythm Disorders. Now the first thing is what happens with the sinus node. Most of the things that happen with the sinus node at the beginning is really sinus bradycardia. When you have sinus bradycardia, sinus brady and sinus tachycardia, the management of sinus bradycardia is almost exclusively what's the management of the underlying cause. Well, by definition, the heart rate normally runs between 60 to 100 beats a minute. That's a normal heart rate. If it's under 60, it's bradycardia. Well, what happens mostly with sinus bradycardia is that you could be a marathon runner. Well, you could just be excessively trained. You could be on a medication like a beta blocker, a calcium blocker, digoxin, that blocks down the RSA node. However, the management of sinus bradycardia, if there's no symptoms, is what is the management of the underlying cause. Now, if you have a person that has a sinus bradycardia and has symptoms, even if it is some marathon running or swimming or some form of thyroid problem like this, if you have acute symptoms, acutely symptomatic, the acutely symptomatic patient is managed first with atropine, and if the atropine doesn't work, a pacemaker. Depends on what the etiology is, except if you're symptomatic. If you're symptomatic, well, symptomatic people need to get atropine. What's the symptoms of bradycardia? Lightheadedness, hypotension, woozy, disoriented. No symptoms, no treatment. Sinus bradycardia, symptoms, atropine, the best initial treatment. Pacemaker, most effective treatment. Now, if the symptoms don't get better with atropine, you would use a transcutaneous pacer, acutely. If the symptoms don't get better with atropine and the transcutaneous pacemaker doesn't work, transvenous pacemaker. Sinus bradycardia, no symptoms, no treatment. Yes symptoms, atropine followed by pacemaker. Now, first degree block, second degree block, and third degree AV block. First degree AV block means a big nothing, no treatment. Second degree AV block means that if it's Mobitz 1, no treatment. Mobitz 2, a pacemaker. And that's the divided line here. First degree AV block gets nothing. Second degree AV block, if it's a Mobitz 1, gets nothing. If it's a Mobitz 2, you have to put in a pacemaker. Pacemaker, make me a match. There, third degree AV block, pacer. Third degree AV block, pacer. Now, first degree AV block, our PR is greater than 200 milliseconds. Well, the most common reason for most of these rhythm problems is the conduction system becomes a little ischemic, a little crotchety, a little old. It's like hair loss, gray hair. What happens? If there's no symptoms, you leave it alone. First degree AV block, see where the QRS is a little bit big? The PR interval is a little prolonged, where the PR is a little bit prolonged like this. When the PR is somewhat prolonged, you don't do anything about it. It doesn't get worse. Mild PR prolongation does not progress to getting any worse than it is now. First degree does not go on to becoming second degree. Second degree doesn't automatically go to third degree. Mobitz 2 progresses. Mobitz 2 gets worse. Mobitz 2 evolves. Mobitz 2 progresses, Mobitz 2 gets worse, Mobitz 2 evolves. So therefore, ready? Mobitz 2 gets worse. Mobitz 1 goes nowhere. Symptomatic, atropine. Symptomatic, atropine and pacemaker. Asymptomatic, do nothing. First degree AV block, prolonged PR, do nothing. Second degree AV block, the Mobitz 1 is a wanky buck. Mobitz 1, the PR gets longer and longer and longer and drops longer and longer and longer. It drops. Although I wouldn't like my PR to get longer and longer and longer and drop, PR progressively prolonging with the wanky buck means that you have a person that is just aging in the conduction system. They don't need therapy. But they're dropping. Yes, but they're just aging in the conduction system. They don't need therapy. Mobitz 2 is much worse. It doesn't progressively progress, it just gets to dropped beat. Now here's Mobitz 1. See this PR? Then this PR gets longer, then this PR gets longer, then drop. You don't have to do anything about it. No therapy for MOBITS1. The PR gets longer and longer, drop. Whereas MOBITS2, it stays fixed, and then just dropped. MOBITS2, whether you're symptomatic or asymptomatic, you're getting a pacemaker. MOBITS2, whether you're symptomatic or asymptomatic, you're getting a pacemaker. MOBITS1, no pacemaker. MOBITS2, a pacemaker. Third degree AV block. See these P to Ps? P to P, P to P, that's a P, that's a P, that's a P, everywhere a PP. Old MacDonald had an EKG. P-O, P-O, P. You see that? The P to Ps are constant. The R's to R's, the R to R, the R to R is constant. No matter what the symptoms are, and when you have a third degree AV block, the third degree AV block must always get paced. You could have a sudden loss of consciousness. That's a Stokes-Adams attack. I'm walking down the street, I'm feeling fine. And then two Irish guys named Stokes and Adams. One is in 1828, the other in 1847 in Ireland. In between pints of Guinness, find me passed out on the floor. These guys described bradycardia, hypotension, and canon A waves. Bradycardia, hypotension, and canon A waves, Stokes-Adams attack. If they're acutely symptomatic, atropine. If no matter what happens, pacemaker. Pacemaker, just atropine first if you're acutely symptomatic. A Stokes-Adams or Adams-Stoke attack is the sudden loss of consciousness from hypotension brought on by third degree AV block. Now, supraventricular arrhythmias are much less dangerous. Supraventricular arrhythmias are much less dangerous because you don't live off your atrium. You don't live off your atrium. Supraventricular arrhythmias are much less dangerous because you live off the ventricle, not off the atrium. Sinus tachycardia is always managed by managing what's the underlying cause. So what's the underlying cause of making my heart beat? What makes my heart beat so fast? Maybe I'm just in love. Well, it could be, because the etiology of sinus tachycardia is the etiology of give me all the diseases in the world that make me uncomfortable. I'm in pain, I'm in fear. I'm in fever, I'm in anxiety. I have hypoglycemia, I have a fever. Anything that causes increased catecholamine output. So that's almost like telling me anything, any disease, like what makes a sinus tach? You sick. You sick with what? Name it. Name it that make you sick. From hypotension to congestive failure, from a pulmonary embolus to anemia, and all the psychological problems in the world. But paroxysmal supraventricular tachycardia is different because sinus tachycardia has a P wave. Sinus tachycardia has a P wave. And supraventricular tachycardia has no P wave. And that's the big deal here. Has ectopic, in other words, it is basically a circle around the AV node, but no P wave. There's no P wave to it and you're tachycardic. Now remember, atrial tachycardia and supraventricular mean pretty much the same thing. Atrial and supra. Supra means above. Ventricular, above the ventricle. What's above the ventricle? The atrium. So atrial tachycardia and supraventricular tachycardia pretty much saying the same thing. Re-entry means that as you're going from the SA node here down to the AV node here, well, what's happening is that you're having a circle of re-entry around, around the AV node. And what's ended up happening, that's why you have no P waves, no fibrillatory waves, and no flutter waves. It's circling around the AV node. Now, this thing is on average SVT. On average, SVT is